I'm Rod Rourke. I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat. Please enjoy.
Hi, and welcome to the June 2017 edition of the PRS Journal Club podcast. I'm Chad Purnell, PRS Resident Ambassador from Northwestern, and I'm joined by my co-ambassadors Jordan Frey from NYU and Shuja Shafqat from Lehigh Valley. Today we have the honor of being joined by Dr. Deb Johnson, the current president of the American Society of Plastic Surgeons. Thanks very much, Dr. Johnson, for joining us for this PRS Journal Club podcast.
Thanks, Chad. It's a pleasure.
So the article we'll be discussing now is Early Postoperative Results of Percutaneous Needle Fasciotomy in 451 Patients with Dupuytren's Disease by Drs. Molenkamp, Schouten, Broekstra, Werker, and Muhlenberg from University Medical Center Groningen in the Netherlands. As a quick reminder, all of the articles that we will discuss can be read for free on prsjournal.com, including an archive of all past Journal Club articles. Just as a quick introduction to this article, percutaneous fasciotomy has been a treatment option for Dupuytren's disease since the 1800s, and it has a reported low complication rate. However, multiple studies have shown that recurrence rates after this procedure have been quite high. And so the authors wanted to report their early outcomes of this technique and compare this to the prior literature. The study is a single surgeon series of 470 fingers with percutaneous release that were performed between 2004 and 2014. So they included fingers if their total passive extension deficit was greater than 30 degrees. So essentially the extension deficit of all the joints of one ray added together was greater than 30 degrees. And so their technique for percutaneous release is they perform this under local anesthesia only. They utilize an ultrasound to locate the cord, and they locate this in relation to the flexor tendon. And then they section the cord at multiple levels using a 25 gauge needle. After they've sectioned the cord at these multiple levels, then they rupture the cord with passive extension of the digit. After that, they have a pretty relaxed postoperative protocol. They don't talk a lot about doing hand therapy or splinting, but they just kind of release patients after that, and they're seeing a mean of 8 weeks postoperatively. And at that point, they measured all of the results and statistically analyzed them. Looking at their results, they performed release on 669 joints in 470 individual rays. And so these joints were 373 MP joints, 274 PIP joints, and 22 DIP joints. Their mean pre-op extension deficit was 37 degrees for the MP joints, 40 for the PIP joints, and 31 for the DIP joints. And then after they performed their technique, looking at their patients about a mean of 8 weeks later, they corrected about 95% of the MP joint contracture, 75% of the PIP joint contracture, and 74% of the DIP joint contracture. They performed a pretty complicated statistical analysis, making sure that they corrected for the multiple measures that were being performed on these patients. And they showed overall that MP joint contractures got a more effective correction than PIP joints or DIP joints, which is pretty consistent in line with previous literature on this technique. They also noted that as the extension deficit became more pronounced, so if the patients had an even more of a flexion contracture from their Dupuytren's, the percutaneous release didn't work as well. So they didn't formally look at recurrence, so they didn't follow patients multiple times throughout the series in order to measure their recurrence. But what they did measure was they looked at the number of patients who underwent a re-release. Out of their initial patients, only 21 underwent a re-release, and these patients underwent this at a mean of about 32 months postoperatively. And finally, looking at complications, so they had an 11.9 overall complication rate, with skin tears having a rate of 9.1%, a 1.1% rate of superficial infections, and a 1.3% rate of paresthesias. They had one patient who had a permanent sensory loss after this technique, and they also had one patient who had a tendon rupture. And the tendon rupture actually occurred very early in their series, and they modified their technique afterwards. So they started performing ultrasound in order to identify where the cord was in relation to the flexor tendon to help avoid a rupture. In their discussion, the authors note that the advantage of the study is the large sample size and also their linear mixed model statistics, which correct for those multiple measurements, as I had mentioned. In general, they show that percutaneous fasciotomy is an effective treatment for Dupuytren's with 95% correction of the MP joint and 75% correction of PIP joint contractures. They noted that the mean durability of the procedure was 32 months. However, the authors did not, as I had mentioned, rigorously follow up these patients, and they didn't use an angle measurement for contracture as a definition for recurrence. So their rates of reoperation are likely decreased as to what the actual recurrence rate was. In general, they note that percutaneous release is an option for patients with mild to moderate Dupuytren's. They also note that the correction rate is similar to collagenase, although the collagenase studies used slightly different measurement techniques, so they can't be directly compared. I thought this was a good paper, and I agree that the authors show that the technique does get a good correction of mild to moderate disease, especially at the MP joint. However, my concern with this paper is that they really don't adequately show recurrence. They're not following these patients appropriately in order to determine the actual recurrence rate of deformity after this procedure. I think really for that, you need strict follow-up and you need strict definitions of recurrence as well. There's a lot of factors that could cause a patient to seek reoperation, and I think there are a lot of confounders in that, and so that's really not the best measure of recurrence. However, what the authors have shown, in my mind, is that this is a relatively easy, local anesthetic only procedure that achieves good correction. I think for patients that don't want the long recovery of a limited fasciectomy or patients whose insurance won't cover collagenase, I think this is a good option as long as the patients understand that there's going to be an increased recurrence as compared to a more open procedure like a limited fasciectomy. So Dr. Johnson, I'll go ahead and open it up to you and see what you thought of this article.
I thought this was pretty interesting. They did try to give it some rigor with their statistical analysis, but it was unfortunate that it was a retrospective study and they didn't really have very good follow-up of the patients to know what the long-term outcomes were. But, if you look at Stromberg's article from the Hand Journal last September, they were also in the Netherlands. They did a randomized trial of collagenase versus percutaneous fasciotomy. And they showed very similar results between their two groups, that the degree of correction and the degree of recurrence were not statistically different between the two groups. Sometimes what's old becomes new again. I think it's interesting. One of the articles that I read talked about how since collagenase was developed as a treatment for Dupuytren's, the number of patients treated for Dupuytren's has increased significantly. And, is that because we have a relatively easy treatment that doesn't require a lot of technical ability, and perhaps collagenase is being used by non-hand surgeons or non-plastic surgeons to treat some of these contractures early on? That may be the case. But it also shows that just because we have a fancy new collagenase kind of treatment, it may not work any better than, good old-fashioned needle fasciotomy. So I think it's valuable to us to compare those two modalities and decide, in a given patient, if they can't afford collagenase or their insurance won't pay for it and they don't want a limited fasciectomy, then doing this sort of needle fasciotomy might be a reasonably good option for them.
Great. Yeah, I agree with everything you said. This definitely has a role, and I think that every surgeon is going to have to decide where this is going to play a role for their treatment of Dupuytren's disease. So with that, I kind of want to jump off into a question of what do you consider the indications for a minimally invasive treatment for Dupuytren's? If a patient's coming to you and they've got a pretty significant contracture, and they want to know whether they should have a limited fasciectomy or if they should have something like a percutaneous fasciectomy or collagenase. What do you think are the relative indications for using one or the other?
If you've got a contracture at the metacarpophalangeal joint and you can get a good correction with a less invasive kind of procedure, then I think that's a reasonable option to offer that patient. As we all know, the PIP and DIP are much trickier. And so if someone has a more aggressive kind of contracture at the finger joints, then I tend to steer them towards a surgical correction because I think that will ultimately give them a better result. But, there are those patients that perhaps have a bothersome minor contracture that you think, well, if it's only 5 or 10 degrees, maybe I can just do something simpler with a needle fasciectomy or with collagenase. Or if they've got medical comorbidities that make you concerned that they would not heal well or be as tolerant of a fasciectomy, then that certainly might be an option for you. The thing I took away from this is that we kind of jumped on this collagenase bandwagon, but perhaps, in good surgical hands, a needle fasciotomy is really just as effective.
I think that's a good point, and it's easy to jump on some of these newer things, but collagenase is expensive, no question about it. And so certainly a needle fasciotomy is definitely going to be cheaper to perform than to do a collagenase injection. Jordan, what did you think of this study?
I thought it was an interesting study. This is something, honestly, I have not really seen or done much. So it's interesting to read about. And I think, like we're kind of talking about it, I think it has a role in it. It's figuring out where that role kind of begins and ends. That's the interesting and kind of the most important part. One interesting thing I thought reading it was their practice of imaging these patients to assess the relation of the cords and tendons to neurovascular bundles. I thought that was interesting. And I don't know, Dr. Johnson, if you could comment on that briefly. Is that something you've done or seen done, or what are your thoughts about that?
I thought that was kind of intriguing. What did they say? Something like their second patient, they had the tendon rupture, and so then they switched to ultrasounding all the patients from there on out. If the tendon rupture had happened in the last patient, they wouldn't have done that. But I thought it was an interesting way to monitor the anatomy. I do some ultrasound of breast implants, and it's difficult enough to tell what's going on. I can't imagine in a fifth digit being able to figure out on ultrasound where everything is. Seems technically a little tricky to me, but they must be good there in the Netherlands. The Stromberg group didn't do any ultrasound, and they also had one tendon rupture in their series. They also had a tendon rupture in their collagenase group. So it's not necessarily a surgical misadventure, but perhaps just the stretching of the tendon that's been contracted for a period of time. It's interesting being able to visualize where the neurovascular bundles are and perhaps how adhesed the tendon is to the cord would certainly be helpful if you had that facility with ultrasound. I don't think it's absolutely necessary, but it probably gives you a little more secure feeling if you're able to visualize where that needle is in relationship to the actual tendon and to the neurovascular bundle. I think the percutaneous fasciotomy works best in those people with pretty central cords rather than having, natatory cords or, more complex kind of fascial tightening. So it's an interesting idea. I like the fact that if you were really good at ultrasound, you could see all those parts and it would make you feel more secure in trying to do that percutaneously.
I think that was an interesting caveat, and I guess it's, our attendings are always telling us you're always treating your last complication. I think they seem to think it was helpful, but I agree, take a skilled technician. Shuja, what were your thoughts about this paper?
I actually really liked this paper. I thought it was really good. I thought they had a really good statistical analysis, clearly. I agree with Dr. Johnson about the ultrasound, and they didn't really mention if they did or did not offer percutaneous needle fasciotomy to patients as a result of their ultrasound, if the neurovascular bundles were too close to the cord or if the flexor tendon was too superficial. Did they say that those patients weren't a candidate for percutaneous fasciotomy? So I kind of agree that it was a little bit of an interesting addition. I think that they show pretty strongly that percutaneous treatment can be effective. Especially what was interesting is that there was no really difference between primary and secondary treatment, and that it can be offered pretty readily to patients even as a secondary treatment after they've had it once. There's two things that I would have liked to see, and I agree with Chad about the analysis of recurrence. They harped on that in the introduction, that was really the main disadvantage of this technique. So I think some analysis of that would have been helpful. But kind of playing devil's advocate, I think what was really striking is that only 21 of their patients underwent a second fasciotomy as a result of needing it or requesting it. And that was even after 2.5 years. So I think on the flip side of that, subjectively, even if there may have been some recurrence, it really didn't seem like it was high enough to warrant any reintervention. But again, the follow-up was kind of variable. Secondly, their complication rate was pretty low and mostly minor with skin tears, but I would have liked to see some analysis, whether it was probably not statistically significant due to low numbers, but any preoperative factors that would have predicted for complications. For example, if a patient had a higher total passive extension deficit, would they tend to have more skin tears or less skin tears? But otherwise, I think that this paper really shows that we can treat patients effectively, and especially as patients may be working longer and retiring at a later age, a method that shows low complications and may allow patients to return earlier to work would be of huge benefit. One thing that I think was interesting and I find interesting to discuss is from a cost and resource utilization standpoint. This method is clearly minimally invasive and cheaper, but may have a higher potential to be needed again in the future compared to a limited fasciectomy that may cost more overall in resource and time and is more invasive but may have a higher success rate with a lower recurrence rate. So Dr. Johnson, what's your opinion on this paper from that standpoint? And do you think we should be using this method more frequently because it's cheaper, or should we be still going for the more invasive treatments because they're more successful in theory?
I think what you'd need is a head-to-head comparison of limited fasciectomy with the percutaneous, and I don't think we have that study yet. Certainly in people with an isolated cord, a single digit involved, doing something, percutaneous or collagenase certainly seems like your first line. Some people with more complex multi-fingers or more complex contractions, I don't think that you can get enough correction percutaneously or with collagenase to give them enough improved function, and then they have to give consideration to the limited fasciectomy. So I think this made me feel like perhaps we should be offering more less invasive procedures for the less complex patients, and then perhaps the limited fasciectomy for those patients with more complex degrees of contracture or more digits involved. It made me think about being a little less aggressive in the future. I think it's something to talk about. When you're a resident, you want to operate. You want to do the biggest operation you can, because that's a learning process for you. But I think it's interesting to look at simpler ways to take care of things and have people with less downtime. And if you can get a significant improvement in their function, then less is more.
Yeah, I agree. I think this paper definitely clued me into offering this to patients more in the future in my practice than I probably would have before I read this paper. So I think that that's a good point. Chad, do you have anything final for us?
Yeah, I think I just want to echo what everyone has said. I think that this article really highlights that you do get a good correction from this technique. And although this article doesn't really answer the question of what's the recurrence rate, I think it's important to realize that this is something in our armamentarium for Dupuytren's contracture. And whenever patients desire a relatively quick and relatively fast recovery from their correction, I think this is a great option. With that, we'll end our discussion of this article. Remember to tune in to the other 2 articles that will be discussed on this month's podcast, as well as the PRS Journal Club podcast that will be broadcast every month. Also, don't forget to participate in our monthly Twitter hashtag PRS Journal Club, where we'll be able to interact directly with this month's selected articles' authors. And thanks again, Dr. Johnson, for joining us.
Oh, thank you. Chad, Jordan, Shuja, I think you guys are doing a great job. I really enjoyed listening to the podcasts, and I know a lot of our members tune in. It's really a good resource for plastic surgeons around the country. So really appreciate you guys taking the time to do this.
Thanks a lot.